communication on the vaccine is not so much about who delivers the message, it's about how do we build a trusted ecosystem that makes vaccination an easy choice.
HPV vaccination is a critical step for us to contribute to eliminating HPV-driven diseases.
We'll be diving into how we can build effective partnerships that support relevant and timely vaccine conversations.
People are rejecting science. They are looking for someone to trust to help them understand it. The most important lesson is that good communication starts by listening.
Hello. Welcome to episode 2 in our series exploring how we can make constructive conversations that support informed patient decision-making on HPV vaccine. The title of this episode is called Broadening the Tent, Effective Communication Partnerships for HPV Vaccine Introduction. In episode 1, we explored the diverse individual, cultural, and communication influences that coalesce to create what is broadly termed vaccine hesitancy. But here in episode 2, our focus is going to be on the communication strategies and skills needed to engage diverse stakeholders and meet patient information needs. We'll be diving into how we can effectively broaden the tent and build effective partnerships that support relevant and timely vaccine conversations. I'm Dr. Linda Eckert, and I'm the podcast series host. I am a physician and obstetrician gynecologist at the University of Washington in Seattle, and I have worked for over 30 years on vaccines and specifically HPV, and also had the opportunity to work at the World Health Organization on guidelines for HPV vaccine as well as cervical cancer prevention. Recently, I authored a book entitled Enough Because We Can Stop Cervical Cancer that highlights women's stories and uses their stories as a communication tool to spread the news of how we can prevent this preventable cancer. I'm really delighted today to be joined by Dr. Laura Termini from Brazil, Dr. Andreas Jo from Cameroon, and Dr. Mridu Gupta from India. I'm going to let them introduce themselves and tell us briefly about their experiences with HPV vaccine and communication in their communities.
Thank you, Linda. I've spent many years working as a scientific researcher on HPV and cervical cancer in Brazil in the Cancer Institute of the state of São Paulo. But over the years, I realized that even with strong scientific evidence, we kept hearing the same question from friends, families, parents, and even healthcare professionals. People are rejecting science. They are looking for someone to trust to help them understand it, someone to explain what HPV is, why vaccination matters, and how it can protect their children. That's what brought me into HPV awareness.
Thank you so much for that. And now, Dr. Jo.
Thanks, Linda. I am Andreas Jo. I'm a medical doctor working with Cameroon's Ministry of Health as Deputy Permanent Secretary in the immunization program. And I've been working in the Ministry of Health for over 13 years now, and in vaccination services for 10 full years. And during this period, I've been able to roll out the HPV vaccine in the subnational level from 2020. And since 2021, I am facilitating vaccination services nationwide from the national level. I have played a critical role in advocacy and in guiding policy for HPV vaccination coverage improvement and HPV vaccination of girls and also boys in the country.
And Dr. Gupta?
I'm Mridu Gupta, and I lead an organization called CAPID in India. I have a background in microbiology, and I have been in the development sector for over 32 years now. I work with communities across education and healthcare. And we started CAPID, Cancer Awareness, Prevention and Early Detection Trust, in 2014. And for over a decade, I've worked on improving HPV vaccine awareness and access through community-based cancer prevention programs. We work largely for cervical cancer, but also for breast and oral. And HPV vaccine has been a large part of our advocacy for the longest time. Now, of course, in India, it has come into policy. Our work has been focused on building trust and working on the misinformation, as well as partnering with governments and healthcare providers and communities to make prevention accessible.
Thank you so much, all of you, for joining. It's wonderful to have a group of individuals talking together that crosses oceans and the equator. We're in the 20th year of the HPV vaccine. We've had a lot of opportunities to learn, both the good and the bad, even the ugly. And I'm wondering if each of you can share examples from your own experiences where you work and live. The rest of us could maybe learn from, either as an example of positivity or as a cautionary tale.
So from our experience, we've been in the field for the last so many years. We've realized that communication on the vaccine is not so much about who delivers the message. It's about how do we build a trusted ecosystem that makes vaccination an easy choice. Considering that we have the science, we have evidence, and even then, if taking the vaccine is a difficult choice, then either we are not getting the right message across or we are not delivering it in the right way. We've seen that this communication, this delivery of the message, it's more like a relay race. All the stakeholders have a certain amount of trust capital. So if the government announces the vaccine, that's a certain amount of trust that they've built. And some people, that's enough for some people to go and take the vaccine. However, the others who don't take the vaccine, it's not a no. They just need more information. And then the community health worker comes in. She adds her bit. She adds a little bit more trust. That is sometimes enough for people, sometimes even not then. Then they need other trusted voices, like maybe an NGO or the community leaders of other kinds, somebody who's proven their trustworthiness or who's delivered before. They add their voice. And eventually they come to a doctor and the doctor adds their voice. So what we really feel is important is that all of these stakeholders are giving the same message. The message is the same. It comes across from multiple angles. That ecosystem makes taking a decision on vaccination a very easy one. But if one person in this entire ecosystem is passing on the wrong baton, is not giving you the same information in this relay, then it leads to doubt. Then people prefer to, err on the side of caution. They don't go forward for the vaccine. So it's not so much about who is the right person. It's more about all of these stakeholders coming together to get the message. For the HPV vaccine, I do believe that ecosystem is what we need to create on the ground. We have experienced that and with communities.
Thank you. That trust ecosystem, what a key point. Dr. Joe, do you have some experiences you'd like to share?
Yeah, of course. HPV vaccination has been a great success story worldwide because this brought hope, preventing diseases that are a major problem touching people in all parts of the globe. And in Cameroon, cervical cancer is a major problem, the number one cancer killer in women in our country. And so this vaccine came up to address this major issue. But I must note that HPV vaccination in Cameroon, like in many other low and middle income countries, began about 15 years after most developed countries started vaccinating their population. And in addition to this, the vaccine was introduced just to girls, a decision that sparked a lot of controversy from local authorities, traditional rulers, and religious leaders who advised the population not to let their children vaccinated. And with this, Cameroon's HPV vaccination introduction in 2020 was marked by very low coverages, even 3 years after the first dose coverage remained at less than 20 and the second dose coverage remained at less than 5. And with this observation, the country was guided by its National Immunization Technical Advisory Group to engage in gender-neutral vaccination, vaccinating both girls and boys, alongside engaging key opinion leaders like religious authorities and other traditional leaders with key messaging to guide the process. And the Ministry of Health adopted this approach and started vaccinating boys and girls. This approach actually stimulated vaccine uptake. And by the end of 2023, we realized a threefold coverage improvement in girls' first dose HPV vaccination, moving from 20 to over 60% coverage. And boys' coverage at this early stage was above 30%. It was a great improvement for a country that could barely reach a 20% coverage for the first dose. And moving with the single dose approach for both boys and girls was critical to address logistic challenges. And so a single shot solved a lot of issues in our vaccine rollout. In addition to vaccinating boys and girls, the approach the country adopted was periodic intensification of routine immunization. So various rounds of periodic intensifications were organized across the country, and this came with mass and interpersonal communication within the community. And the approach brought key messages to parents, to leaders, community leaders, and other authorities who understood why we should vaccinate girls and boys against HPV. This facilitated rapid uptake of HPV vaccination for girls in Cameroon and also for boys, and contributing to disease control more effectively.
Thank you for that. That's really fascinating to decide and make that bold choice to add boys to the vaccine schedule, and to try to use that as a bridge to help everybody understand how prevalent and widely impactful HPV is. Dr. Termini, do you have some insights from Brazil you can share with us?
Brazil is a continental country with very diverse geographic, social, and cultural realities. And that's reflected in the way healthcare is delivered. Brazil has one of the world's largest public immunization programs. HPV vaccination was introduced in 2014 for girls and expanded to boys in 2017. Over the past decade, experience has shown that having a strong national recommendation is essential, but communication and implementation need to be adapted to local realities. So the Brazilian Ministry of Health provides the national framework while state and municipal health authorities adapt implementation according to local needs. One of the most important insights has been that communication needs to be adapted to the way healthcare is delivered. For example, in more urbanized regions, adolescents can be reached through schools, primary healthcare services, pediatrician, vaccination campaigns, or social media. Now, let me give you a very different example from the Brazilian Amazon. The Brazilian state of Amazonas has vast underserved river areas, with rivers are the only way to reach many communities. And in these communities, healthcare itself follows the river network. So healthcare teams travel long distances by boat to provide vaccination alongside other essential health services. Although the national recommendations are exactly the same across the country, communication needs to reflect local realities. So healthcare professionals work together with schools, local leaders, families, NGOs, and civil societies organizations to explain why the healthcare team is coming, answer questions, and encourage families to participate. But at the heart of this collaborative effort are trusted community health workers, because they are already known by the local families. They help prepare communities before each visit, and information spreads through trusted conversation and sometimes word of mouth. So by the time the healthcare boat reaches the community, families already know why the team is there. Many of their questions have already been answered, and the community is already engaged. That's why experience from other vaccination programs has shown that same principle applies here. Communication doesn't begin when the healthcare boat arrives. It starts long before. The national recommendation is the same, the vaccine is the same, but the communication should follow the same path that healthcare takes. And perhaps, Linda, the most important lesson is that good communication starts by listening. Different communities have different questions, concerns, and experiences. Listening first help to provide information that is relevant to each community rather than simple delivering the same message everywhere.
That makes a lot of sense. And I think it's a fascinating example of dealing with rural populations that are reached by rivers and needing the messengers to be there before the healthcare workers get there. That's really interesting. We all are thinking about how we can use community health workers and be part working with our communities. I just was curious if other people had examples of this broad tent approach, how you bring in other vaccine communicators. Why have you chosen those strategies? And if people might speak to that.
For us, I don't know how it is in other countries, but in India, doctors don't have much time. They have all the information, of course, but they usually don't have that much time with each person that they're going to explain to you the science behind it or the rest of it, which is why you do need people to understand about the vaccine even before they come. The doctor will reinforce the information. They will probably give you the right information, give you the direction, explain all of that to you, but not enough to sit there and convince you to take the vaccine. Which is why we realized that all of that, even like you were saying in Brazil, all of that needs to be done beforehand. People need to have enough information when they come to the doctor, and the doctor will reinforce it, which is why we needed to build that information across multiple stakeholders. We've also spoken to teachers, though, of course, teachers were not the first choice for parents when they are making a health decision. But a note from the school, a letter from the school is something that helps, that convinces them. If they're, you're sitting at the wall and you're not really decided, it kind of convinces you more. So we need to bake that information across multiple stakeholders. But what kind of information was needed? That was a challenge. We realized that things that talk down, or they are like a top down kind of an expression where it doesn't give people enough information. So we have to speak at their level, but we do need to bring the science to them. We do need to give them enough to convince them that they need to get to go there and make. So the decision is ultimately going to be theirs. And in India, lately, we've realized that the vaccine is being rolled out for 14-year-olds. Therefore, it's not just the parents. Those girls are old enough to make their own decision. They're old enough to push back. They're old enough to say that we don't want, I'm not going today, or whatever. And usually at that teen years, if your parents want you to do something, you do not want to do it. So I'm sure that's a bigger challenge in their homes, but that's besides the point. So if it was a 9 to 14, I can imagine getting the information to parents and, that working. But in India, currently, the challenge is that it's for 14-year-olds only. So we are having to now create communication for parents as well as for teenagers. So we need them to have enough information, and they are curious. Of course, they're going to ask you for more. They're not going to listen to you saying, go get an HPV vaccination. So we are now building digital content. We are building little animated videos that give you bits and pieces of the information, something that they would look at. So the entire communication strategy has changed. It's more online. It's more suited for them. It's something easy for them to share. They might send it to friends. They might send it to their girl group, things like that. That was what we were thinking about. So strategy has changed for communication because now we are addressing parents and teenagers. And we are also addressing their ecosystem. So now we have to have enough that community health worker will get into it, the teachers will get into it, more than the doctors. All this time it was HCP-led, but now we are looking at the broader ecosystem and enough communication for them to be able to share it. These days, they're very quick with that. So it has to be short, has to be quickly shareable, and it has to interest different age groups and different stakeholders. So that's where currently the strategy with communication is for us.
Thank you. That's really interesting. And it brings up the idea of gatekeepers. You're thinking about the teenage girls being their own gatekeepers, their own controllers of whether or not they get these. We can widen the tent, as we know, but we need people to walk through that tent door. And so, Andreas, I wondered if you could speak to what approaches you've used to reach out to the gatekeepers, identifying who those are, who are the decision makers, and how do you try to influence the people that are making the actual decisions about the vaccination?
Of course, Linda, the approach we use generally has been improving every day. From the onset, it was a routine approach, just routine vaccination against HPV, but this was marked by really poor uptake. And from 2023, with the gender neutral vaccination approach and periodic intensification of routine immunization, we adopted an interpersonal approach to communicate, and also mass communication was used. And this targeted key influential people, including religious authorities, traditional leaders, and local administrators, alongside parents. And they got the right information. They understood why we should vaccinate girls and boys to control and to eliminate HPV-driven diseases like cervical cancer. A step that really greatly improved vaccination coverage, protecting the population. And as the days go on, the country is gradually shifting to integrate screening, especially cervical cancer screening and HPV communication, HPV vaccination. Today, the Ministry of Health is strongly collaborating with its partners and local organizations, including the Joe Foundation in community, that carry out cervical cancer screening. And during this process, there is interpersonal communication and also mass communication, focus group discussions that permit parents and other community actors to understand the key issue and how to prevent HPV-driven diseases like cervical cancer. It's also a platform where people get more aware of those around them who have either died from disease like cervical cancer or are sick due to HPV-driven diseases. It also provides the platform where people are screened for HPV and these precancerous and cancer lesion. And in the course of this, people understand more why they should engage in HPV vaccination, why they should support it. Some because they have a relative that has been affected or they themselves have been directly affected, become advocate because they realize that though they were unable to protect themselves because in the past there wasn't any vaccination, today they can protect those around them, their daughters, their sons, the future woman, the future man in our community. And parents immediately take the message to homes, to their families, encouraging their girls and boys to get vaccinated. I must note that although the girl and the boy have critical role in decision making for HPV vaccination, the parents have a critical role to guiding HPV vaccination. They will tell the children, this is good for your health. It will keep you healthy. It will prevent you from getting sick like the other neighbor. And this promotes HPV vaccination. Alongside these, parents also contribute to sharing the message with their peers. And the community approach also is a platform to strengthen information, educate the public, educate key decision makers, enablers in our communities. And in that light, a huger proportion of the population and decision makers and influencers get the right message and turn up to support more the process of HPV vaccination for girls and for boys, and screening to be able to identify lesions in the adult population linked to HPV to prevent their evolution, manage them timely, and handle complications promptly.
I think that we all realize we want to work with gatekeepers and we need to equip them with the accurate information so that they know how to help their communities and their families make good decisions. I wondered if anybody had any information or examples of how you tried to address specific information or skills that might be needed by enablers. I know, for instance, in our clinic, we've worked with grandparents. We really try to help the grandparents understand why this is a good vaccine, because we find that grandparents actually have a lot of influence over whether their grandchildren take the vaccine.
So I can tell you that when we go into communities to do screening for cervical cancer, we always look for these older women who are really strong and who are outspoken, and we get them to come in and be screened first. And once she is screened, she is like an enabler. She will bring other people and she will force them to come, and she'll say, no, it doesn't hurt. It takes 2 minutes. Go and get screened. So we do know that when you start the communication, you need somebody from within them. And usually it's these elderly women who are forceful enough and everyone looks at them and they're trusted. So I know it works in screening. We haven't used it in vaccines yet about building that. We usually look at parents. But yes, I can imagine that it would work similarly for vaccines as well. However, we have found that community leaders like self-help group leaders and things like that, they are strong. So in the village governance system in India, we have the panchayat, and the panchayat has the head who would be the pradhan of the village. And they're usually men. When we speak to him, and if we can get him to understand the vaccine, and as a male, and if he was to talk to other men in the community, we definitely get a good outcome for the vaccine then in the village. So in societies like ours, which are largely patriarchal, really getting the men to come on board, getting them to understand the value of the vaccine, we found that that helps to get families and to get communities to come on board for the vaccine.
One thing I've also seen is teens mobilizing to tell other teens about the vaccine. And that's been very effective because, of course, peer to peer education of teens is a wonderful tool to use. And so getting the teenagers information that they will share, they're going to brand it, they're going to make it fit their own social media, they're going to take it and run with it. That's been a really powerful communication tool that I've seen a lot of communities use here in the United States.
I have a son of 13 years old, and I get in touch with a lot of teenagers at home with the family of these teenagers. I use this moment to spread the HPV information, not only to the teenagers, but to the parents. They really need a simple way to understand it. And it was very successful.
I used to do the soccer sidelines. My sons played soccer or football here, and it was a great way to talk to parents as we're all watching, ask if they have any questions, and try to spread the news just organically in that way. Well, thank you very much, all of you, for your wonderful contributions. I think we've heard a lot about how to build trust ecosystems. I would like to refer all the listeners of this to askaboutHPV.org. That's the IPVS website. It contains a lot of resources. So you've heard us talk about different tools. There's many tools available. You don't have to reinvent the wheel. And I think the askaboutHPV.org website is a wonderful opportunity. Certainly, the World Health Organization has wonderful resources available, and also national organizations or NGOs within your own communities. So I just wondered if we've missed anything, if anyone has any closing thoughts they'd like to share as we wrap up this episode 2 of our podcast series.
I think that families everywhere want to protect their children. Making vaccines available is essential, but helping people to understand, trust, and access vaccination requires communication that needs to be adapted to local realities. When we understand local realities, listen before we speak, and work together with trusted local partners, communication becomes more than information.
Thank you, Linda, for this great session, and thank you to the other peers from the other countries. HPV vaccination is a critical step for us to contribute to eliminating HPV-driven diseases, especially cervical cancer, which is a major problem worldwide, and especially in contexts like Cameroon, where it is the first cancer killer in women's population. And alongside integrating in other health activities and other community intervention is key to strengthen messaging, population awareness, vaccine uptake, and also contributing to eliminating HPV and cervical cancer.
Well, I'd like to thank all the listeners. I certainly would like to thank the International Papillomavirus Society for making this series available online. And again, reach out for resources. We all have this tool that we're excited to use as we keep marching on toward our elimination of HPV cancers. And hopefully the first will be the cervical cancer elimination. Thank you very much.